I want to begin by telling you about the last days of this gentleman who in his time was the most famous physician in the world. Don't feel bad if you don't recognize his face, but I'm sure you recognize his writing. This was Anton Chekhov. Chekhov famously said that medicine is his lawful wedded wife and literature is his mistress. What you might not know is that Chekhov died very young. He died of tuberculosis. And just before he died, the year before he died, he married an actress by the name of Olga Nipper, even though they both knew that he was going to die. And then in the weeks before he died, he asked her to take him to the Badenweiler Spa in the Black Forest of Germany. And because he was a dying man, she obliged him and she took him to the spa. And when he first got there, he did very well. His color was better, he improved. But then one night, he began to cough, and he was coughing up a lot of blood. It looked very bad. And so they called for the spa physician, a man by the name of Dr. Schwerer. And I'm now about to recite to you something from the biography of Chekhov by Troyat, describing that last scene. And it goes like this. The windows were wide open, but Chekhov could not stop panting. His temples were bathed in sweat. When Dr. Schwerer arrived, Chekhov sat up, and in a final reflex of courtesy, he mastered his weak German to say, "Ich sterbe, I'm dying." Dr. Schwerer ordered a camphor injection, but Chekhov's heart did not react. Dr. Schwerer was about to send for oxygen when Chekhov, lucid to the end, said, "What's the use, doctor? Before it comes, I will be a corpse." And so, Dr. Schwerer ordered a bottle of champagne. And when it came, Chekhov said to his wife, Olga, "It's been so long since I've had champagne." He had a glass, he lay down, he turned over to his left side. After a few moments, he stopped breathing. He had passed from life to death with characteristic simplicity. It was 3 o'clock in the morning, July the 2nd, 1904. A large black-winged moth had flown in through the window and was beating against the lamp. Dr. Schwerer withdrew after a few words of consolation. All at once there was an explosion, a joyous explosion. The cork had popped out of the champagne bottle. The moth found its way out of the window into the night. Silence returned at last. At daybreak, Olga was still sitting there staring at her husband's face. She would say later that it was peaceful, quiet, knowing. She said, there were no everyday sounds, there were no human voices, there was only beauty, peace, and the grandeur of death. Now, I don't know about you, but I've always loved that passage, not just because of the poignant description of Chekhov's death, but also because of Dr. Schwerer. I've had the honor or the misfortune in my life to take care of several dying physicians, and I know it's a very difficult thing. And I feel sorry for Dr. Schwerer, who's called in to see the most famous physician in the world who's dying. And yet somehow Dr. Schwerer manages to connect with the patient, recognize that the medical issues are beyond anybody's fixing, and he does this magical thing of ordering the champagne, which then seems to set in motion everything else. Chekhov has a glass, he turns over, he passes away, the cork pops out of the champagne bottle, the moth flies out into the night. It's a reminder of the kind of interaction that a physician can have with a patient, which extends well beyond medicine. Now, the picture on the left that you will see is a picture of William Osler, famous American physician, who died in 1917. And it used to be that the only source of our data was the patient. And we had to inspect, palpate, percuss, auscultate the patient. But nowadays, the great danger is that this is what medical rounds looks like because we have so much data to deal with. And we become more and more focused on the computer screen. I actually coined the term the eye patient to describe the virtual entity of the patient in the computer. And that entity gets a lot of attention. The eye patient is getting great care all across America, for example, but the real patient often says, where is everybody? What is going on? And there's a good reason for this. We have so much more data to deal with. We have so much more information on each patient. This is the era of big data. Everybody's talking about big data. I came across this slide, which I thought was interesting. It said, big data is like teenage sex. Everyone talks about it. Nobody really knows how to do it. Everyone thinks everyone else is doing it, so everyone claims they're doing it. But there is no doubt that we do have a lot of data to juggle on top of dealing with a human being. Recently, this little drawing caught the attention of physicians all across America. It was published in the Journal of the American Medical Association, and it was drawn by a 9-year-old child. And you can see in the picture she draws that she's seated on the exam table. Her mother is next to her, maybe reading a magazine. Her little sister is next to the mother, playing with a doll. And the doctor is looking at the computer, facing away from the child. And I must tell you something about this doctor. This doctor is one of the most dedicated individuals you could ever meet. His life dream was to be a pediatrician. He loved children. He spent 1 year as a pediatric resident, then went and joined the Navy for 2 years to serve his country, came back to continue his pediatric training, had 3 children of his own. And when he saw this diagram, when he saw this figure, he was very depressed. He felt that this was the price of technology, that he was losing the very thing that had made him want to become a physician in the first place. So what I'd like to do, ladies and gentlemen, in the minutes I have left to me, I would like to make the case why even in this era of big data, even when we have all the information we need about the patient in a computer, it remains important to examine the patient, to talk to the patient, especially to examine the patient. I'm going to give you 3 good reasons why that's the case. The first reason has to do with what I call the low-hanging fruit. I don't know if that's an expression that is popular in medical circles here, but it's popular in America. The idea being that there's fruit that you can pluck with your hand. You don't need a ladder, you don't need a machine, you might as well pluck it. Similarly, there are very obvious diagnoses that we can make, that we should make, but we're not making as often as we used to. If you look at that yellow line, in the 1940s and earlier than that, bedside diagnosis was the only way to make a diagnosis. And now our skill has gone down so much so that that patient that you see on the bottom right, that patient has a condition called Horner syndrome. If you look carefully, his right eyelid is a bit droopy, and his right pupil is small. And the cause of that is a tumor inside the lung. That kind of patient, and it's happening because there's an interruption of the sympathetic nerve supply that eventually goes to the eye. That kind of patient has been recognized for 100 years, but we are missing that kind of patient more often because we've become so dependent on our technology. In fact, I had this cartoon commissioned. It says, let's get a CAT scan and consult the gastroenterologist and figure out why you're having those pains. We have begun to distrust our eyes, our ears, our senses, as though we can't make a diagnosis without technology. And that's not true. We can still make many, many diagnoses with examining the patient. And the second reason for us to examine the patient with some attention is because of the phenomenon that we're recognizing that 50% of physicians in North America are stressed and disillusioned about medicine. 50%. So you know it's not a personal problem, it must be a systemic issue. Something is wrong with the system. And I think the main thing that's wrong with the system is that there's too much red tape. I like this particular figure. It's taken from a colleague of mine from his textbook called Red Tape, looking at, he's an anthropologist, looking at red tape in the Indian government. But it's a nice image because it reminds me of how we have our own kind of red tape in medicine. I practice at Stanford. I'm at a very busy hospital. But for every 1 minute or so that I spend with the patient, I need to spend 3 to 4 to 15 minutes on the computer documenting what I just did. And that sort of red tape is making our lives more and more stressed, making us more and more unhappy. And so something has to be done about that. But most importantly, the thing that I really want to talk about, the third reason why we should continue to examine the patient, is because the ritual of examining the patient is so important. Recently, I had a friend who's a cardiac surgeon. He's now retired, and he's been having shoulder problems. So he went to see the best shoulder surgeon perhaps in the world, someone whose reputation is on reconstructing shoulders. And that surgeon immediately received him very warmly and had his ultrasound technician do the ultrasound of the shoulder, because for surgery, ultrasound really will tell you the state of the tendon. Even though your exam can show you a lot of things, the ultrasound has become the way to do it. And the technician did the ultrasound, presented the results to the doctor. The doctor then presented the results to my friend, the cardiac surgeon, and told him that he didn't think there was any role for surgery. It was a very good visit. He felt very well treated, but he told me, I was disappointed that he never put a hand on me. And I said, he didn't need to put a hand on you. He had all the information. He says, yes, I know that, but it's still important. And that anecdote points out to me that the ritual of examining the patient is a very, very important ritual. If you think about it, one individual, the patient, is coming to another individual, a stranger, and telling them things that they would not tell their husband, their wife, their priest, their rabbi. And then incredibly, they are undressing and allowing touch, which in any other context would be an assault. Not only that, but the exam is happening in a very specialized room. The furniture in the room does not look like anything in your house or my house. Not only that, one person's wearing a ceremonial white gown, the other person's wearing a paper gown. It has all the trappings of ritual. And from my anthropology colleagues, I've learned that rituals are all about transformation. We engage in rituals to signify the crossing of a threshold. We engage in marriage, we engage in funerals, the passing of power, by having a ritual. Well, I would submit to you that the ritual of one person allowing someone else to examine them in this specialized setting is a very, very important ritual. And you might ask, what is the transformation that happens when you examine someone if it's a ritual? Well, the transformation is the sealing of the patient-physician relationship. The transformation is the location of the illness on the body as opposed to some screen somewhere. The transformation is validating the symptoms and signs of the patient on the body. That is the transformation. That's why it is so important. More than that, we're learning now that science has sort of come together with ritual. There's a lot of information now about the placebo effect. We know that placebo is much more than giving somebody a sugar pill. We know that when you give a placebo, you can measure neurobiological changes in the people who respond. For example, if you give Parkinson's patients who are shaking, if you give them a placebo, 20 to 30% of them might respond. In those who respond, you can measure dopamine levels going up in the brain. Or you can give placebo to somebody with pain. In the 30 to 40% who respond, if you then give them a morphine antagonist, the pain comes right back. In other words, placebo produces real neurobiological effects. And Benedetti coined this term, the placebo without a placebo, meaning that ritual, context, tone of voice, setting, all these things matter in bringing about the placebo response. I want to close by quoting another writer who's a favorite of mine. His name is John Berger. He's won the Booker Prize twice. And one of his books, for which I know him the best, is one called A Fortunate Man, where he follows an English country doctor around for 1 year and seems to get into his head and to really understand the philosophy of medicine. And he shows how the doctor that he's following, Dr. Sassel, changes. Initially, when he's very young, he's fascinated by emergencies. He loves operating on the kitchen table and delivering in a caravan. But as time goes on, he develops a much more mature understanding of the nature of medicine. And I love the following passage. He says, an unhappy patient comes to a doctor to offer him an illness in the hope that this part of him, the illness, may be recognizable. His proper self he believes to be unknowable. In the light of the world, the patient is no one, but by his own lights, and by his own lights the world is nothing. But if the man can begin to feel recognized, and such recognition may well include aspects of his character which he's not yet recognized himself, the hopeless nature of his unhappiness will have been changed. He may even have the chance of being happy. Ladies and gentlemen, Mother Teresa said famously that one of the greatest diseases is to be nobody to anybody. And I think the great joy of being a physician, the great privilege, is that we're allowed into people's lives at a very special, vulnerable moment. And they may be nobody to anybody, but they will always be somebody to us. As Peabody said many years ago, the secret of the care of the patient is in caring for the patient. Thank you very much.